Welcome back, focused learners, to another explainer. Today, we're unraveling a high-stakes microscopic heist that happens inside the human body every single year. It's a biological true crime story, really, where the culprit is a total master of disguise. It's incredibly efficient at breaking and entering, and it's responsible for global chaos. We are talking, of course, about the influenza virus.
It's a fascinating question, isn't it? Why does a microscopic lipid bubble keep outsmarting modern medicine year after year? Well, this virus belongs to the orthomyxoviridae family, and what's absolutely mind-blowing is that it operates with just 8 little segments of RNA. Yet those 8 tiny strands hold the exact blueprint needed to infiltrate our cells, hijack our internal machinery, and spark widespread respiratory mayhem.
Okay, let's dive into this. Here is our clinical roadmap for today. First, we'll meet the viral infiltrator, look at its antigenic disguises, identify high-risk victims, break down the severe complications, explore medical diagnostics and antivirals, and finally, look at the shield of vaccination.
Section 1. Meet the infiltrator. So at its core, influenza is what we call an enveloped, negative-sense, single-stranded RNA virus. Basically, that just means it's wrapped up in a lipid envelope that's studded with the critical tools it uses to execute its heist. And the absolute most vital tool in its whole arsenal? That's hemagglutinin, or HA. You can think of HA as the ultimate biochemical lockpick. This surface glycoprotein specifically hunts down and binds to sialic acid residues on our host epithelial cells, especially in our upper respiratory tract. It's literally the glue that forces the door open so the virus can get inside.
But, getting in is really only half the battle. The virus also needs an escape plan. Enter Neuraminidase, or NA. Once the virus has hijacked our cell and manufactured thousands of viral clones, those clones actually get stuck. They bind to that exact same sialic acid on their way out. So neuraminidase acts as the essential getaway scissors. It cleaves those sialic acid connections so the newly formed viruses can release, escape, and spread the infection everywhere else. So if we trace the exact steps of this biological break-in, it flows beautifully. Step 1, attachment via hemagglutinin. Step 2, the host cell actually swallows the virus into a pocket called an endosome. There, acidic protons rush through the viral M2 ion channel, which acts like a trigger for the virus to uncoat. Step 3, that released RNA travels right into our nucleus to rapidly replicate. And finally, step 4, the new viruses bud off and are released via neuraminidase cleavage. The perfect crime.
Section 2. Antigenic disguises.
Let's move to and see how this builds, because this brings us to one of the most frustrating things about this virus for epidemiologists: its ability to completely change its appearance. It evades our immunity through 2 completely distinct disguises. The first is antigenic drift. Since viral RNA polymerase is pretty sloppy and makes mistakes, tiny point mutations start to accumulate. This causes minor structural changes to the hemagglutinin and neuraminidase. It's kind of like the virus just changing its jacket. This is what gives us localized seasonal epidemics. But antigenic shift? That is a completely different nightmare. This isn't just a minor wardrobe change. This is a massive, novel reassortment of RNA segments that creates a completely terrifying new identity. And this is exactly what sparks global pandemics. And this brilliantly illustrates exactly how an antigenic shift happens. Think of pigs as the ultimate genetic blenders. Their epithelial cells naturally have receptors for both human and avian flu. So if a pig happens to catch a human strain, like H3N2, and a bird strain, like H5N1, at the exact same time, those 8 RNA segments from each virus can mix and match right there in the cytoplasm. When they repackage, they can birth a totally novel threat. We're talking about a virus with the lethality of a bird flu combined with the easy transmissibility of a human flu. Section 3. High-risk victims. Now, while this virus can infect just about anyone, the fallout from this heist doesn't impact everyone equally. We really need to look at our high-risk populations, and these distinct buckets are absolutely crucial to remember. We've got the immunocompromised, like HIV patients or transplant recipients, and folks at the extremes of age, so kids under 5 and adults over 65. It also heavily targets patients with chronic lung or heart diseases, like COPD, asthma, coronary artery disease, or congestive heart failure. But pay very special attention to pregnant patients and the morbidly obese. Not only do they face unique immune challenges, but the physical pressure on their diaphragm creates what we call restrictive lung physiology. It makes it incredibly hard to breathe if a severe respiratory infection sets in. That physical restriction is exactly why your doctor pushes the flu shot so hard if you or a loved one fall into these specific categories. Section 4. Severe complications.
Let's slow the pacing down a bit here. Now, most people just experience an uncomplicated upper respiratory tract infection. But when the viral heist moves deep into the lower respiratory tract, things go catastrophically wrong in two distinct ways. First, there's primary viral pneumonia. This is caused directly by the flu itself. It hits fast, causing diffuse bilateral alveolar destruction across both lungs. Secondary bacterial pneumonia, on the other hand, is a trapped bacterial superinfection. It sets in after the initial viral damage is already done. It usually shows up as a localized lobar consolidation, meaning a really dense, fluid-filled pocket of infection confined to just one section of the lung, usually caused by heavy-hitting pathogens like Staph aureus or Strep pneumoniae.
Let's look a little closer at primary viral pneumonia. The influenza virus directly attacks and destroys our type 1 and type 2 alveolar cells. When it destroys those type 2 cells, it completely halts the production of surfactant, which causes the tiny air sacs, the alveoli, to collapse. Meanwhile, destroying the type 1 cells makes the local capillaries incredibly leaky, so protein-rich fluid just floods right in, literally drowning the lungs from the inside out. This is known as acute respiratory distress syndrome, or ARDS, and it requires intense, immediate hospitalization. Then, there's secondary bacterial pneumonia, which is notoriously treacherous because of its biphasic nature. Biphasic meaning two phases. Here's what happens. The patient gets the flu, they suffer for a few days, and then right around day 4, they actually seem to recover. They feel better. But during that initial viral phase, the flu destroyed their cilia, those tiny little sweeping hairs in our airways. Without cilia working to clear out debris, deadly bacteria like MRSA or Streptococcus pneumonia just get trapped in the lungs. They rapidly multiply, suddenly plunging that recovering patient into a severe, localized bacterial pneumonia. Section 5. Diagnostics and antivirals. With such severe complications on the line, we obviously need strong medical counterattacks. To launch these, we first perform PCR swabs on our high-risk patients to rapidly pinpoint the viral strain. Once we know what we're dealing with, we deploy targeted medications. So the crucial point is how these drugs actually intervene in the viral life cycle. Take oseltamivir, which you probably know as Tamiflu. It's a Neuraminidase inhibitor. It literally jams those getaway scissors shut, meaning the newly formed viruses can't bud off and escape the cell. Alternatively, a newer drug like baloxavir acts even earlier. It inhibits the endonuclease activity of the viral RNA polymerase, which just completely shuts down viral replication altogether. Now, you might be wondering about some older drugs, right? Like amantadine, which was originally designed to block that M2 uncoding channel we talked about earlier. Well, thanks to the sheer evolutionary prowess of this virus, a staggering 99% of current circulating influenza A strains are completely resistant to it. 99%. Amantadine is virtually obsolete today. Section 6. The shield of vaccination. Since treating the flu once you have it is kind of an uphill battle against viral mutation, our ultimate defense is pre-exposure security. We want to proactively generate memory B cells and neutralizing antibodies before the virus ever even breaches the perimeter. We essentially have 3 main vaccine shields at our disposal. The inactivated vaccine is the standard injection for pretty much everyone over 6 months old. Notably, high-risk elderly patients require a massive quadruple dose or a special adjuvant just to wake up their aging immune systems. Next, we have the live attenuated nasal spray, which is fantastic for building mucosal immunity. And finally, there's the newer recombinant vaccine for adults, which offers an exact genetic match to the circulating strain. Understanding these options really empowers you to advocate for the right protection for you and your family. Now, while that live attenuated nasal spray is a fantastic option for healthy folks between 2 and 49, we have to be very clear about who is strictly excluded. Because it is a live, albeit weakened, virus, we absolutely cannot give it to pregnant patients, the immunocompromised, or those at the extreme ends of age. Crucially, we also exclude patients with COPD or asthma. The live virus could actually trigger a dangerous immediate bronchospasm in their already susceptible lungs, and we definitely want to avoid that. Which brings us to a really fascinating comparison in how these vaccines are actually made. The traditional inactivated vaccines are grown in egg cells, but there's a slight problem with that. The virus can undergo minor mutations while incubating in the egg, which slightly reduces the vaccine's final real-world efficacy. The newer recombinant vaccine completely bypasses this issue. By synthesizing the viral RNA inside insect cells instead, it avoids those manufacturing mutations entirely.
The result? A highly effective, 100% perfect genetic match to the target virus. A real game changer.
So, we've unpacked the virology, the devastating complications, and our best medical defenses. But we have to leave off on a bit of a sobering note. As influenza continues its rapid evolutionary arms race, constantly drifting and inevitably shifting inside genetic blenders like pigs, are we truly ready for the next novel reassortment? It's a high-stakes war that is far from over. Thank you for joining me for this explainer, and stay curious.